Welcome, Dr. OYELEKE. Can please go ahead? Yes.
Good afternoon, everyone. And my name is Dr. OYELEKE Ganiyat, as she introduced me. So this afternoon, we'll be discussing hepatitis B virus and pregnancy, the best practices in the management of hepatitis B virus infection during and after pregnancy. So we'll start. I'll start with a brief outline of what I'll be discussing, the introductions and definitions, epidemiology, hepatitis B transmission in pregnancy, the features, investigations, the treatment both during and after pregnancy, and the prevention. So by way of introduction, when we say hepatitis, for the purpose of today's discussion, we're discussing just an aspect of what hepatitis means. We know hepatitis means liver inflammation. In fact, the word hepatitis is derived from two Greek words, hepatitis, that means liver inflammation. So hepatitis B virus infection is caused by a virus. So the name of that virus is the hepatitis B virus. We know there are different types of those viruses. We have hepatitis A, hepatitis B, hepatitis C, D, and E. So this is just a description of the molecule, what's the hepatitis B virus, the structure rather of the virus. We know it is a DNA virus and it belongs to the Hepatnaviridae family. So that virus, as we know, affects the liver. That is where it causes liver inflammation. Next slide, please. So in terms of epidemiology, it's always good to have a perspective. Nigeria, with an estimated population of like 190 million people, has a prevalence of 8.1% of hepatitis B. We also have hepatitis C, about 1.1. And this is based on the recent NAIS reports, which was done late 2019 to early 2020. The previous prevalence was even much higher than that. And the range of it's like a range of prevalence. It ranges from about 4% in the south to almost 20-23% in the northern parts of the country. Studies and prevalences locally in Nigeria found that for hepatitis B virus in pregnant women, a study in Abuja found about 7%, while in Lagos, a study at Luth found a similar pattern, about 7.3%. So you can see that we have a national prevalence of about 8.1, and we have about 7.3% even in the pregnant women. In America, the prevalence is about 2% of the general population, and the range of 0.7 to 0.9% amongst pregnant women. So you can see that it's not as common in some developed countries as we have here. Also, globally, we know it's a disease that affects everyone, but we can see the pattern in some parts of the world, particularly in sub-Saharan Africa. We have about 60 million people infected with hepatitis B, while the Western Pacific has a higher level as well, and lower in some other parts of the world. So this is just a picture showing the global prevalence and global epidemiology of hepatitis B virus. Next slide, please. Next slide, please. Okay, so in terms of transmission, so the transmission of hepatitis B is envisioned in two major parts. So we know we have the perinatal transmission, which is transmission from mother to infants. And this usually occurs during childbirth, majorly during childbirth. While we have horizontal transmission, and the horizontal transmission could be from a child to another child through blood. There has to be blood contact or blood body fluid, or contaminated needles, or sexual contact, or blood transfusion, or needle pricks, or use of sharps and all that. So those are the horizontal transmission from person to person, or vertical transmission from mother to child. We're focusing today on that aspect of mother to child. Next slide, please. For hepatitis B transmission in pregnancy, we know that approximately 40% of infants born to infected mothers will develop chronic hepatitis B. And data suggests that 90% of infected children, so we have 40% of the infants from infected mothers will have it. Of these 40%, 90% of them will go ahead to develop chronic infection. And an estimated 25% of these individuals will die prematurely. And what will cause the death? Either liver cirrhosis, which is advanced scarring inside the liver as a result of chronic inflammation, or even which is hepatocellular carcinoma. Continued prevention of perinatal transmission is an essential component of the ongoing efforts to decrease the worldwide impact of hepatitis B. Perinatal hepatitis B transmission can be prevented by identifying the infected mothers and treating them and providing prophylaxis for the infant. So that single importance of preventing this mother-to-child transmission as much as possible has a long-term consequence to the family and to the society at large. So how do we identify hepatitis? It's always a challenge because we hear most of the patients who tell us, nothing was happening to me. I was well, I was okay, nothing. I just went for a routine test and I was told I had it. So it's important to let people know that for most times you may have no symptoms. So it's usually and mostly asymptomatic. No symptoms at all. No body pain, no headache. For some people, they may have fever or jaundice or malaise or body pain or passage of dark urine or abdominal pain or anorexia or nausea. Some may have one of all this, which can easily be attributed to maybe malaria, if you have fever and body pain. If you have abdominal pain, you may think it's something you've eaten. So there may be no specific symptoms, so it's good for us to understand it. And we also know that some patients will also present with signs of complications, which unfortunately is what we see a lot, particularly in the tertiary setting. So the symptoms and signs of complications could be ascites, which is abdominal swelling, or hepatomegaly, which is enlarged liver, or shrunken liver. So, the liver can either enlarge or it reduces in size. And these are signs of liver cirrhosis, which I mentioned is advanced scarring or advanced fibrosis within the liver. And that can be complicated by what we call portal hypertension, in which the person presents with features of, we say, esophageal varices. So they can start to vomit blood, or they can start to pass blood into large volume of blood that may result into even then going into shock. And of course, liver cancer. So sometimes you see patients presenting with a hard mass in the liver. And at that time, we know it's far too late for anything to be done. How do we investigate? That's the next thing. If we have a patient, next slide please. If we have patients with hepatitis, what do we do? So we have a whole panel of what we do. Once the person tests, the first test that we usually do is the HBsAg, so which we call the hepatitis B surface antigen. The surface antigen will tell us if it is positive, if there's an infection, or if it is negative, if there is no infection. So usually we advise all pregnant women. I know that is being done in most parts of Lagos State, or I think it's like compulsory now. All pregnant women must have hepatitis B surface antigen done. and hepatitis B surface antibody. If you do not have the infection, we want to check if you have protection. So the surface antigen tells us there's an infection. The surface antibody, this one, tells us there's protection. So if the surface antigen is negative, then we know that, okay, let's check if the surface antibody is positive. If that is not positive, the woman may require immunization. But if the surface antigen is positive, then we go ahead and do the other panel. So we do the hepatitis B envelope antigen, which is known to be the mark of infectivity. It's the one that tells us the virus is replicating very, very fast. We can also do the antibody to that, so the hepatitis B envelope antibody, and do the hepatitis B core antibody. The core antibody tells us if you have a new infection, or an acute or recent infection, or if you have a chronic or a long-standing infection. So if the IgM for the hepatitis B core antibody is positive, we know it's an acute infection. Whereas if it's IgG that is positive, we know it's an old infection. Then we go ahead and do what we call the hepatitis B DNA viral load, or hepatitis B DNA quantification. And that seems to be the hallmark on decision of treatment, which we'll get to later on. We know this is expensive, and we know how it is for people around to get by with money and all that. So there are several recommendations on when you cannot do viral load, what else can you do, which we'll discuss later. An average hepatitis B viral load costs about 20 to 50,000 naira, depending on whether you're doing it in a government hospital or you're doing it privately. Then we go ahead and do the liver enzymes. And the liver enzymes are AST, ALT, GGT, gamma glutamate transferase, and alkaline phosphatase. And we also check for the liver function. We know the liver produces albumin and protein, and below the liver also synthesizes the clotting factor. So we check all this as well. We do a full blood count just to have a background and check the platelets. In severe liver diseases, the platelet count is markedly reduced. So we'd like to check all this. I would assay the kidney function using the electrolyte urea, because we know that kidney function is important because kidneys can be complicated even in liver disease. And we also want to prepare the person for medication if that is going to be necessary. Then we do an abdominal ultrasound. So these are briefly the investigations we request for in pregnancy. Next slide, please. So there's a recommendation by the Center for Disease Control, and they recommend that there should be a universal screening of all pregnant women for hepatitis B surface antigen during each pregnancy. So you hear someone will say, oh, I did that in my first pregnancy. This is the third or fourth pregnancy. So the CDC recommends for each pregnancy, you must do the surface antigen. The screening of all hepatitis B surface antigen positive pregnant women for hepatitis B DNA. This is important to guide the treatments, the antiviral therapy. The AASLD is the American Association for the Study of Liver, and it suggests that once the viral load goes more than 200,000 international units per ml, then the treatment should be commenced at a particular time of pregnancy. And there must be case management for each patient and all that. Provision of immunoprophylaxis for infants born to infected mothers. And what do we mean by immunoprophylaxis? The immunoprophylaxis includes the hepatitis B immunoglobulin that's given within 12 hours of birth, along with the first dose of the hepatitis B vaccine within 12 or 24 hours of birth. So once it's done, then the patient continues to receive the complete hepatitis B vaccine series. But it's important that this, the first dose of the hepatitis B vaccine must be, is either you give it alongside the hepatitis B immunoglobulin, or you give it within the first 24 hours of birth. Next slide, please. The WHO, the World Health Organization, also recommends that pregnant women testing positive for hepatitis B surface antigen with a hepatitis B DNA of similar to what the American Society concluded. If you have a viral load of greater than or equal to 200,000 international units, they must receive tenofovir prophylaxis from the 28th week of pregnancy. That's like the last trimester of pregnancy, until at least they give birth. This helps to prevent mother-to-child transmission. This tenofovir does not mean that they still will not require the birth dose of the vaccine. So it's important that they get that to help to reduce and prevent the risk of the woman passing the infection to the child. And we've already stressed why we do not want kids to be infected, because we know an infection in infancy results into 90% chronicity. And a quarter of that, 25%, will die prematurely. So it's important that we prevent all these things from happening. And tenofovir is given at the dose of 300 milligrams daily. Hepatitis B in pregnancy, I must stress at this level, it's not an indication for cesarean section. I know we used to have that thought in the past, but newer studies are showing no benefits once we take all these precautions into place. Then the second recommendation, because I know what is going in our head is now, if we say that the viral load costs between 20 to 50 or 60,000, an average Nigerian really may not be able to afford that. And the World Health Organization is aware of this. So they also recommended that in settings in which the hepatitis B viral DNA is not available or maybe not affordable, we can do the hepatitis B envelope antigen testing as an alternative. And I stressed earlier that this envelope antigen testing is the one that tells us that the virus is replicating very fast. It's a mark of infectivity of hepatitis B infection. So if we can do this, averagely that costs about 5,000 to 7,000. Could be lower in the government hospitals, but I mean it's a lot cheaper than the DNA. And if you do the envelope antigen and it's negative, then you could skip your tenofovir prophylaxis. But if you do that and it's positive, then you should still go ahead and give prophylaxis. Okay? So next slide, please. All right, so what about after pregnancy? So once the child is born, the baby receives the hepatitis B immunoglobulin. The baby receives hepatitis B immunoglobulin. This I'm stressing because we've had cases in which the immunoglobulin was wrongfully given to the mother. It's the child that does not have an infection. The immunoglobulin to the baby at that time is a post-exposure prophylaxis. So you give it into the deltoid within 12 hours of birth. Then you can now also give you must also give the first dose of the hepatitis B vaccine, and you continue with the second 2 or more doses. I think in Nigeria, we give a full 4 doses as part of the NPR, either at 4 to 6 weeks, at 10 weeks, and 14 weeks. The baby can be breastfed, but we usually recommend that they take that vaccine or immunoglobulin within so the 12 hours of 24 hours, then the child can commence breastfeeding. So it's important to stress this. It is not when we should give the vaccine that they will say, oh, it is not immunization day, come back next week. The woman must be aware. They should make provision and she inform the hospital where she's going to give birth about this. For places where they cannot afford immunoglobulin, because that is another big issue. Immunoglobulin is very expensive as well. It costs between 55 to 60,000 naira for a dose for a baby. So if they cannot afford this, the first dose of that vaccine, the hepatitis B vaccine, which is given for free anyway, must be given within 12 hours. So we have to stress this. If the child of the, if the mother cannot afford it, or if that is not available, we have to make sure that we do, we give the vaccine and they complete the series as well. So the World Health Organization had a campaign for 2020. Incidentally, just about 3 weeks ago, less than 3 weeks ago, was World Hepatitis Day. And the focus for this year's World Hepatitis Day for the WHO theme was towards a hepatitis-free future. And we know that maternal to child transmission is a major aspect of this hepatitis-free future. So what do we need to, what are the areas of focus? Next slide, please. Next slide, please. So the WHO focuses on 5 main areas. And the first one is prevent infection amongst infants. How do we do this? All newborns should be vaccinated against hepatitis B at birth, followed by at least 2 additional doses. At least, in Nigeria, we do 4 doses. That means birth dose and 3 other doses. So that is the recommendation. So we must emphasize this and we must make sure that they follow this. The second focus, next please. The second focus is what we're discussing and what we've been talking about. We need to stop transmission from mother to child. So how do we stop this transmission? We need to test all pregnant women for hepatitis B, and we need to treat them. We've talked about treatment, what's the indication for treatment when the viral load is more than 200,000 international units, which is the guideline that we, the Society for Gastroenterologists and Hepatologists in Nigeria, SOGIM, will follow as well. And it's the same WHO recommendation. 200,000 IU per mil of the DNA, or presence of hepatitis B envelope antigen. If it's positive, then from the 28th week of pregnancy, you can commence tenofovir prophylaxis. Okay, so that we need to emphasize. The third point is that we need to leave no one behind. We have to be inclusive. Everyone should have access to hepatitis B prevention. And I mean, I usually start this talk with how many people have actually been immunized, even amongst the participants of this project. So we need to preach hepatitis testing. We do not want to wait until symptoms start to appear before we start running up and down. So everyone must be included in the screening, in the prevention, in the testing and treatment services. And when you say everyone, we mean everybody. So we can't leave anybody behind that, oh, the prisoners are not inclusive, or this one is just this or this one. So we have to make a lot of efforts. And the next focus by the WHO is, next slide, please. Is the expansion of access. So we need to expand treatment and testing access. It's always challenging because sometimes some would say, I don't even know where to go for testing. So timely testing, timely treatment, and timely referral is very, very important so that we can prevent liver cancer and consequences of hepatitis B viral infection. And the last focus is on maintenance. So we need to focus, right? You need to maintain essential services. This became particularly important during this COVID pandemic. We know a lot of emphasis has been on COVID, but this should not reduce what the emphasis on hepatitis and infant immunization, or emphasis on attempting to reduce harm using different methods of prevention techniques, encouraging individuals to prevent, to avoid infection and all that. Then those that are already getting treatment must also continue to receive treatments that they require, even during this COVID pandemic. Right, next slide, please. So I think I'm almost done. So I'm just leaving us with a conclusion. But the conclusion is because I understand majority are primary healthcare physicians and nurses. And so if you have patients that come, the first thing we say is that during the first pregnancy visits, test them for hepatitis B surface antigen and the antibody to that, which you call the hepatitis B surface antibody. For those that have negative results, that means surface antigen is negative and antibody to that is also negative, you can vaccinate them. Vaccination can be given in pregnancy. It is safe because, I mean, sometimes you hear, oh, and they did not tell me that since they did the test, it was negative, and I told them I had never been vaccinated before, but nobody mentioned anything. So vaccination can be given even in pregnancy. And when the child is born, as is recommended by our EPI expanded program of immunization, the child receives a birth dose of hepatitis B vaccine, followed by 2 or 3 additional doses. For those that are positive for hepatitis B, you want to find out whether they have any active disease. So if, for example, somebody with hepatitis B already has features of liver disease, you just start to treat outrightly. But for those that you've checked the viral load, and maybe the ones that are without symptoms, you have to do the viral load and you have to now follow. Is the viral load more than 200,000? Or is there hepatitis B envelope antigen positivity? Depending on the results, you start treatment at 28 weeks or you do not start treatment. So that is it. So viral load more than 200,000 IU per mil, you consider treatment at 28 weeks or 32 weeks by the 3rd trimester. For those with viral load less than 200,000, there is no need for you to start them on antiviral therapy. You go ahead to deliver the baby. If they can afford hepatitis B immunoglobulin, you make sure you give that within 12 hours along with the birth dose of hepatitis B vaccine and complete the remaining series of the hepatitis B. For those that do not require treatment, like I said, when they give birth, the mother continues monitoring for hepatitis. So we monitor them. It is not all hepatitis B patients that require treatment. For some of them, they are monitored continuously and they would never require treatment. But it's important for them to be monitored. The fact that they do not require treatment at this time does not mean that in about a year's time, they may not require treatment. So this is where I'll stop my discussion. Next slide. Next slide, please. So these are my references. Next slide. Okay, so this is where I stop. I think I have a thank you slide as the last slide. Okay, so still the same thing. For those that are pregnant or for those that are managing pregnant women, you need to let them know that they need to get tested early for hepatitis B virus infection. Thank you very much.
Thank you so much, Dr. OYELEKE. Thank you for your presentation, and thank you for sharing the recent guidelines on the prevention of mother-to-child transmission for hepatitis B. That's a very recent finding. It just came out, I think, on July the 27th, and it shows that you really did your homework in coming to give us this presentation. Thank you so much. So we'll be moving on now to take on the case presentation from Alaji Duse Hospital, and Nurse Patricia Uchenna will be coming on to take us through a case presentation that involves a hepatitis B patient. Over to you now, Nurse Uchenna. Thank you. Welcome.
Good afternoon, everybody.
Yeah. Good afternoon and welcome. The floor is yours.
I'm Nurse Patricia Uchenna from Alaji Primary Healthcare Center, and I'm presenting on the client's name CG.
Sorry, Nurse Patricia, sorry to interrupt you. Could you try to increase the volume a bit so we can hear you? raise your voice a bit. I think because you have your mask on, it's pretty difficult. Yeah, thank you.
All right. Her name is CG. She's age 26 years old, a female. She's married with 2 kids, all are home deliveries. Her level of education, she finished secondary school, and she's a Christian by religion. The next slide. Okay. She registered with us on the 28th of July, 2020, and she was 32 weeks at the point of presentation to the hospital. Her BP was 100/70 millimeter mercury. Her weight was 74 kg, and her height is 1.65 meters. Then going by our BMI calculation, she's 22.1 kg per meter square. And as at the day of registration, this is what we have about her. We sent her for lab investigations, and the results came out. Her RBS result is non-reactive. Her hepatitis B result was positive. The PCV was 31%, which is low. Her sugar level was 3.6 milligram per dl. Her pH was 6.0, and the analysis was clear. There's no glucose, no protein, no blood. Next slide. Based on the outcome of the investigation, she was diagnosed as having hepatitis B with low PCV. There is no past medical history from her because, according to her, her 2 deliveries were at home. So we don't have any previous information on her previous ANCs for other pregnancies. Then regarding her PCV, she was advised on nutrition, what is the food and the habits she should put up for. And then we gave her drugs on that day, routine drugs, which she used to take. And she's still on those routine drugs. And we told her, we referred her to Kubwa General to see a doctor, to which most times they bring them back to us. And then the ones that are serious or presenting with signs and symptoms, they retain them. But most of them, they send them back to us that we should continue with the ANC. And then after delivery, we send them back to them with a referral, a 2-way referral form at the point of delivery to go back to Cuba. So presently now, on that same day, we also told her her husband was called to also come for the test, to which, as at this point of presentation, he has not come for it. But she's claimed that about a year ago he did the test and it was negative. So we are still waiting for them. And then the children, we are yet to ascertain their own hepatitis B status for now. Next slide, okay. Medications given were tablet folic acid 5 milligram once daily, tablet ferrous 200 milligram twice daily, calcium tablet 300 milligram twice daily, vitamin C tablet 200 milligram twice daily, tablet B complex 25 milligram twice daily, and tablet IPT 3 tablets, which is given at a start dose for 3 consecutive times, and then injection TT, tetanus toxoid 0.5 milligram start dose. And her next, based on that, we scheduled her for her next visit to be on the 26th of August, 2020. Thank you.
Thank you. Thank you so much, Nurse Chena. Thank you for that case presentation. So right now, we'd just like to go on to the few questions that have been asked. Please keep the questions coming. I think that's the best way that we're going to be able to learn. So I'm going to direct the first question to you, Dr. Oyeleke. Could you please tell us, this question is from Daughters of Charity Hospital. They're asking, why is it that the patient always asked to come back, is always asked to come back after childbirth for treatment when she can actually be treated antenatally? Could you please help us with that, Dr. Oyeleke?
Okay, so I actually don't know who would be saying that, but usually when they refer pregnant women with hepatitis to us, what we do is we do the profile and we do the viral DNA. So like I've stated earlier, so the profile includes the hepatitis E antigen and all that. So most times we request for all those tests to be done. If the hepatitis B E antigen is positive, then we start treatments. If the hepatitis B DNA is elevated beyond 200,000 international units, then we can start treatments. But if all these tests were done and supposedly the E antigen is negative, for example, or the DNA comes and it's maybe about 100 or 200 or about 1,000, so all we do is, okay, deliver the patient, the baby, but we usually would tell them, in fact, most times we write the prescription and tell the patients that get these drugs because it's expensive and keep it with you, or maybe keep it with in the hospital where you deliver so that they can give it to the child. So that's the best practice. We don't just tell them to go away. We have to make sure that we do the needful. Hepatitis B envelope antigen, hepatitis B DNA if they can afford it, and we make sure that we insist that the child gets at least the first dose of hepatitis B vaccine at birth, even if if they can't afford to buy the hepatitis B immunoglobulin. So that's the best practice. So you can't just tell them to go and come back.
Yeah, thank you so much for that clarification, Dr. Oyeleke. I trust that answered your question at Daughters of Charity Hospital. Thank you for that. This question is from Naomi Olede. She says, is it possible to be positive and yet have a partner who remains negative? And is it possible to fully recover from hepatitis B infection? I think Dr. Oyeleke, could you also take on that for us? I repeat the question from Naomi Olede. Okay,
I got it.
Okay, thank you. Please go ahead.
Know why a partner will be positive and the other partner is negative. In short, I think that's a summary.
Yes.
Okay,
yes.
So there's another twist to the hepatitis B that we've observed, particularly in sub-Saharan Africa, where Nigeria belongs to. Unlike what is noted in the developed country, that hepatitis B virus is majorly a sexually transmitted infection, in Nigeria, we know that it's more of a childhood infection for most people. Of course, we know it can still be sexually transmitted, but the majority acquired the infection in childhood, either from an infected mother, as we're discussing, or from what we call a child-to-child transmission, particularly during play and all that. So that's also been widely reported in most studies. So if you've had the hepatitis B infection in childhood, mind you, most of us might have been exposed to hepatitis, but we're able to clear it. There's a percentage that will still be able to clear the virus. So it's possible that the other partner might have been exposed to hepatitis and cleared the virus and has developed an immunity, the hepatitis B surface antibody. So if you have the antibody, then you will not have an infection. That's one aspect. The other aspect is if you've developed the infection in childhood, then maybe at that point, it may be that the viral load is not so high enough to warrant transmission through sexual. But for those ones, there may still be exposure through blood, if maybe blood transfusion or use of sharps and all. So yes, we've seen a lot of, so we call it discordance now. So the partner is positive and the other partner may be negative because of that.
Okay.
And
the second aspect, oh, go ahead.
There was a second aspect to that question, sorry.
Can I just ask a follow-up?
Yes, so what's the second aspect to that, sir?
Dr. Kendra, you were speaking? Okay. Okay, so the follow-up question to that, Dr. OYELEKE, sorry about that, was is it possible to fully recover from hepatitis B infection? Yeah.
Yes. Okay, so when you have hepatitis B, I always use this to explain to my patients, and I feel it's clear enough. So when you have hepatitis, two things can happen. The virus can run its course, as some virus can do, and clear. So for an adult, there's a higher chance that you will clear the virus. But for a child, there's a lower chance. So we're seeing 90% being chronic, 10% will clear it. So yes, the hepatitis can clear from your system. If you have hepatitis B, within 6 months, the virus can clear. More so if you're an adult, if it's an infection in an adult, than when you're a child. Now, when it clears, it confers you an immunity, and that guarantees that you won't have hepatitis B again. It gives you the hepatitis B surface antibody, or the anti-HBs. So that can happen. Also, it's a small percentage of the people that will develop what we call the chronic infection. And when we say chronic infection, we mean infection that has lasted more than 6 months. A small percentage of those ones also can clear the virus, even though that may take some time. And what they do and all that is we can say is the host immunity that determines that. So we can't tell. In terms of medication, as of today, there's no medication that can comfortably say that, oh, once you use this drug, it clears your hepatitis B. There is no drug like that. There are drugs that we can use, but there's no guarantee that the drugs will be able to clear the virus. Because when we're saying clearing the virus, we're saying the surface antigen will disappear and the antibody appears. But the immunity of the child, is of the host is important in the clearing of the virus.
Thank you. Thank you for that, Dr. OYELEKE. So just a quick one. Also, a follow-up to this question is, so what counseling would you give to discordant partners?
Okay. So I saw somebody put something up in that. So what counseling will you advise them on subsequent sexual intercourse and all that? Mm-hmm. So usually once the partner is infected, right? So how we do it, because we know, because of what we know, that is maybe they've acquired, maybe one partner must have acquired a childhood infection. If it was an adult infection, antigen may be positive and all that, there's a risk that the other partner would have been infected anyway. So what we do, what we usually tell them is that your partner should be tested. If the partner is negative, then let the partner be vaccinated immediately. So what we're testing the partner for would be the surface antigen and the surface antibody. So the antibody, if it's positive, then does not require the partner to be immunized again. So once if the partner has both hepatitis B surface antigen negative and the hepatitis B surface antibody negative, then we would immunize the partner. So immunization is not only for children. We immunize adults. So the same 3 doses or as applied. So that's what we do. So in terms of coitus, so what I tell them is, you've been married for maybe 10 years, and a doctor sees you today and says that don't go near your husband again, or don't go near your wife. We try to be realistic as much as possible. For most of them, I usually just say, you know what, how soon can you do this test? And once you start the first dose of the vaccine, then we can go ahead and have their relationship without any issues. I know for some, they'll feel, I think I'll rather wait until maybe he or she gets 2 doses before we start to meet again. But that is their choice. But medically, there is no subsequent risk if it has not really happened. So we usually don't emphasize that, oh, don't sleep with your husband or wear protection every time you meet. We usually just try to hasten them up to immunization. So that's what we do.
Thank you. That was so educating, Dr. Oyeleke. I will direct this question now to Dr. Doherty. I would want you to answer and let us know the question from Mina Jacobs and answer to that. Please, in the absence of both vaccines for the baby and breastfeeding has already begun, can the baby still be vaccinated for hepatitis B? Can we unmute Dr. Doherty, please?
Ima.
Yes, ma'am.
The question again. I'm
okay.
As well,
okay. Go ahead. Okay, so this is a baby question. So it says, please, in the absence of both vaccines for the baby and breastfeeding has already begun, can the baby still be vaccinated?
So I would say yes, the baby must be vaccinated. As I don't know which both vaccines. You are saying there's no IVIG because the hepatitis B vaccine is available, it's free, right? So the baby must get his or her hepatitis B at birth, right? If we know this is a baby we're following up and the baby has a hospital delivery or is delivered in the presence of a skilled birth attendant, the baby must get her full series of immunizations, including that one that we give at birth. And especially that one that we give at birth. Like you heard Dr. Oyeleke say, that one must be given, even if we are stuck and we don't have, the parents don't have IVIG. Kendra and I have had to deal with this before with Dr. Neka, when my mother didn't prepare upon all the time and all she had been prepared for. But that baby must be immunized no matter what. And then you started breastfeeding. What are you going to do? There's a 10% risk chance that the baby will clear the infection. There's a very high risk that if the baby is not breastfed, the baby will either be malnourished or will develop diarrheal illness. If you're dealing with a mother that can't afford IVIG, I can assure you she can't afford formula. So I would say breastfeed that baby and immunize as quickly as possible. Unless the literature says we should do otherwise. But as of today, this is what we would do. Now, if you don't mind, I have a question for Dr. Oyeleke. Dr. Oyeleke, thank you for coming on. I'm wondering, especially because I heard the story of this young mother now, whom Nurse Uchenna presented. So what is the relationship? Because the man is said to have had a hepatitis screen earlier in the year that was negative. So somebody must have seen something to make him do a hepatitis screen because you know, he must have presented with something. He didn't just, this is a family that has not gone to hospital to deliver before. And the mother said, the wife says he has a negative hepatitis screen. It begs the question for me, one, what are the relationships between the different kinds of hepatitis, B, C, and D, that we see in Nigeria? If we see a mother with hepatitis B, what are the chances that she has an associated other form of hepatitis? And the same for her partner. And do we screen them beyond that, or are the incidences so low that there is no need? Thank you.
Okay, so thank you, Dr. Doherty. So for hepatitis B is a virus, we know. Hepatitis C, D, and E are also viruses. In fact, A, B, C, D, and E. So when a patient is referred to us, we know that hepatitis B, C, and D, they have similar routes of transmission. So we screen them for that. So we screen them for hepatitis C as well. Hepatitis D is like a super infection on hepatitis B. So we don't routinely do that, except we notice some other issues. But so we basically, as part of the screening as part of the follow-up or investigations we request, we do hepatitis C and we test them for HIV. We used to think hepatitis C was not present in Nigeria, but I think we're seeing that, I mean, we have 1.1% by the recent survey by the NAAIS. So we see that, I mean, 1% of 190 million, that's about 1.9 million. That's still a lot.
That's a lot of people, yes.
So that's still a lot. So, and now, but the good thing with hepatitis C is that now it is curable. And we have backings by some NGOs supporting the treatments, reducing the treatments that used to be so unaffordable and unreachable. They've like cut it down to about a quarter. So that's available in the government hospitals. So we do all the screenings alongside. At times makes even routine investigating hepatitis very expensive. Because when they refer to us, we do HIV, hepatitis C, we do the profile, we request for DNA if they can afford it. So those are the things we still do as well. Sorry, I think there's another thing you asked that maybe I've not answered.
Oh, that was it. So basically the interrelationship. Yeah. So if we say we screen for C as well.
Yes, we screen for C as well because they have similar mode of transmission. It's also,
is it as expensive, and can we also manage it, or we just know it's there and we can manage in pregnancy?
Yeah, so we manage C, but for hepatitis C, sorry, I didn't discuss that because I thought we were just focusing on hepatitis B today. So for hepatitis C in pregnancy, what we do is we allow them to deliver. The drugs for hepatitis C, so the drugs available, they have potential teratogenic effects. So we don't use them in pregnancy at all. They're not indicated in pregnancy. So even if a mother was on them and she gets pregnant, we'll stop and we now restart after pregnancy. The treatment is usually for 12 weeks to 24 weeks. So what we tell them when the mother is using it, or a lady, that we say, please make sure there's no pregnancy while you're using this. After we're done with our treatments, which is usually for either 12 weeks or 24 weeks, then you can, get pregnant at that time. Because we don't have anything to prevent mother-to-child transmission of hepatitis C. In fact, we don't have anything to prevent hepatitis C, unfortunately, unlike we have for hepatitis B. So that's what we advise for them. So no treatments for hepatitis C in pregnancy until they deliver, and there's nothing that we can do to reduce maternal-to-child transmission other than precautions and preventive techniques. So that's usually, so I would warn people about, basic primary prevention of, be careful when you go to salon to fix your hair, be careful when you do manicure, or be careful with reusing needles and razor and clippers, all this that we've been talking over and over, we still discuss that with them as well. Someone asked what the dose of hepatitis B immunoglobulin.
Yes, I was coming to that. Yes. So
for a new
the dose of hepatitis B for adults.
Yes. So
hello, Dr. Yeleke.
I'm sorry.
Yeah. Okay, so can I read the question for you?
Okay.
Okay, it says, what is the dose of hepatitis B for adults? And can the vaccine be given to children during immunization? Okay, it says, what is the dose of hepatitis B for adults? And then can the vaccine that is given to children for immunization be used for adults?
Yeah. Yes, you can use the same vaccine.
Okay.
So the dose for children, for adults is 1 ml. So I think sometimes they do 0.5 mils. For kids that are, children that have low birth weight, those are the ones we're being careful to give at birth. So they usually wait until they, maybe after about 4 weeks or so before you administer hepatitis. So, yes. So for the hepatitis B immunoglobulin, we give 180 microgram for, 180 units for newborns, and we give about 540 units for adults. So it's almost 3 times the infant dose that the adults get. So if you are buying an infant dose at 50, you need 150 to take care of an adult. So
Okay, thank you so much, Dr. Oyeleke.
Adults
I'll direct,
and all that.
Thank you, Dr. Oyeleke. So I'll direct this question at Dr. Imiosemi, please. What are the guidelines on partner notification? We have seen situations where some pregnant women are aware of their status but have not shared with their partners and are very concerned about the ramifications if they do. How would you suggest that we counsel them? Dr. Imiosemi, I don't know if you've had such encounters in practice, and probably you could give us an insight to maybe like how you handle them. Yeah. Is Dr. Imiosemi muted or muted, please? Okay. Otherwise, maybe we can, Dr. Oyeleke, we are going to fall back on you again. Or let me address this to Dr. Anyikam as well.
What did you ask? I'm sorry.
Okay. Thanks. What are the guidelines on partner notification? We have seen situations where some pregnant women are aware of their status but have not shared it with their partners and are very concerned about the ramifications if they do. How would you suggest that we counsel them? I know you threw some light on this earlier, or maybe we could just help clarify some more on this.
So we've had these issues a lot, and I mean several situations where what we usually do is to encourage them to bring their spouse, and we try to do that because when they get home and say, so I did a test today and they found that I have hepatitis B. The first thing the man always tells them is that, oh, so you've been sleeping around, which is a tough challenge that we've seen a lot. So they start to like, oh, how am I even sure that this pregnancy is mine? In fact, I've had a patient that the man walked out on them when she was pregnant with hepatitis B. And, so because she said they went to a place and the doctor, the med said that if the man does not leave her, she's going to transfer the hepatitis to him and he'll die of liver cancer. So that was his excuse. It's good for whoever the doctor that they're meeting is to be able to, break this down. So what we do at LUF is that we tell them to invite the spouse over. Don't worry, just tell them that they said we did some tests, everything is fine, but we just needed you to come. And we talk to the partner. So usually we try to like, okay, fine. So hepatitis in our environment, we know it's a childhood infection. It's possible your wife has had this thing since childhood without knowing, because if you've never tested, you will never know. So we'll bring that forward before we say, okay, even though we know that it could be sexually transmitted, but so that is the way we go about it. So we talk to the partner. So it could be, is it that any of the spouses, is that the wife that has it or the husband that has it or not? So we talk to the other spouse and we explain how you can have it. And we explain that with prevention, then we can prevent transmission. Prevention, we can even prevent her from developing liver disease, and also prevent her from spreading it to the children. So that is what we try to do as much as possible. The other aspect, which I usually emphasize, is that in fact, most times when I come, I'll say, most likely your partner will not have this hepatitis, because if you've had it for long, the people I worry about will be your siblings, which we try to tell them. And by tracing siblings, we've been able to trace so many of them that, in fact, we've been able to even diagnose cancers early in the siblings. Because if they all grew up at the same, and maybe they were born by the same mother, they grew up in the same household, there's a possibility that if it was a childhood infection, somebody else in their family will have it. So that is what the other area we're trying to emphasize, that as much as we know it can be sexually transmitted, in Nigeria, it is not a sexually transmitted disease like that. So we try to break it down. And all these, so because I have it, in fact, we had a couple recently, a young couple who came in married. They just newly married. and the husband followed the wife who is positive. They discovered during premarital counseling and testing. And they agreed it's okay to get married and all that. But they decided they weren't going to have kids because somebody had told them that once you sleep with each other, the other partner will get infected. So they took a decision not to have kids and not to even have sexual intercourse. So, I mean, people take it to that extreme. So we need to, it behoves on us to educate them that, okay, I mean, you can go ahead with your sexual life. We'll treat your wife, get pregnant, we'll manage it. So we need to, I mean, demystify all this because majority of patients with hepatitis don't want to come forward because they feel somebody will start looking at them as if, you know, they sleep around. You know, you see so many people say, I'm a pastor, I don't do all this thing. You know, they'll be telling you this as if it's, and I tell them, no, it's not what you do, you did or what you did not do. You probably, maybe it was a casual contact with an infected child, or maybe it was even your mom that had it, or maybe another child in the family. So it's always good to you know, break this down in a way that is easier for them to understand so that they won't think, oh, that the other partner had gone out to do something. That's why this has happened to him or her. Okay?
Yeah. Thank you so much, Dr. Yenike. Really
Hello.
keen to let them know. Oh, Dr. Emesimi, you're on? Yes, please go ahead, Dr. Emesimi.
Okay. Well, let me thank you know, the organizers for coming up with this topic. It's relevant, it's contemporary, and it's been very, you know, illuminating. And I'm sure a number of us were on board because I had to again invite fellow consultants, OBGYN, through other platforms to be part of it because I'm aware that most times one of the things we do when we have HBsAg positive women, especially when we have what we call the discordant couples, because of some knowledge gap and lack of access to current information. I'm talking of information that is evidence-based. We always refer, you know, to the, you know, the gastroenterologist, you know, to establish whether you could have continuous coitus and all of that. I'm aware that some of my colleagues, especially with, you know, with partners that are positive, and when you have a discordance, okay, they run some of these tests, they treat whether you are pregnant or not. If you have, you know, the core antigen or the envelope, the DNA antibodies, you know, that's more than 200,000, they treat with tenofovir and others until the level comes down to below 200,000 before, again, they now encourage, you know, a resurgence or a restart of coitus. But from what we had, this perspective, I'm sure we're a lot wiser. The major challenge for us in our practice is the recognition of the fact that we're able to, you know, influence or reduce vertical transmission. You're going to go a long way in reducing the overall burden. And yet, depending on where you practice, the challenge of, for example, like a number of our centers, you have to send the patients to maybe NIMA, for example, you know, to do some of these tests. We've said a lot about the cost, okay? And the other thing is, and yet you need to establish how infective or how infectious these women are, all right? So how do you get it? So a number of times you have to make do with a lot of, you know, clinical features. We check their liver function test, for example, look at the ALT. And like was rightly pointed out, a number of times we rely a lot on the envelope, on the hepatitis B envelope, you know, antigen. Now the logistics is a challenge. The woman who comes to you, you must convince her that, listen, this thing is manageable, and that, but we need to get a lot of information. I'm sure what I'm saying is what a number of our colleagues do. So to get them to get to NIMA to go and do these tests, there's a lot of waiting time and all of that. But with what we've had today, I'm sure things will be a lot better. Now, the other thing is, these people, these are women deliver over the weekends. The logistics of providing vaccination, I'm talking about the hepatitis B vaccine, which is free over the weekend, something we need to look at. A number of times, activities are usually very low on Saturdays, Sundays. But again, with all that we've had now, of course, we're going back to the drawing board to ensure that some of these simple measures that have been unequivocally, brought up to show that they are very useful. We need to go back to ensure that we address some of these things so that even over the weekend, if the patient cannot, get the HB immunoglobulin, which is a lot of money. But having said that, like has been pointed out, it's our responsibility to let patients know. What I always say is that when patients are booked and when we are doing what we call risk classification, by the time you sensitize the number of these patients, you prepare them, financially and all of that, you'll be so amazed, at the number of people who, having recognized the inherent advantages of immunization, will save towards that. So, like has been pointed, our responsibility is to provide information, evidence-based, that will help reduce vertical transmission, so that overall, the challenge of addressing the hepatitis B problem, will be addressed from this perspective. So these are some of my challenges. I can imagine in areas that are very rural, it will be very difficult, for example, to get somebody from HBV, to come to Lagos Island, for example, to come and do some of these tests. But then the responsibility is ours to emphasize the importance of, these tests, especially with regards to reduction in vertical transmission, and as an alone objective, and of course, as part of the larger, task of reducing the burden of hepatitis. I think those are some of my perspective and experience. And then with the algorithm that has been shared, rather than send patients from maybe the general hospital or the health centers to teaching hospitals where Dr. OYELEKE practices, we can get a number of people to embrace and use some of these things to guide the practice so that, reduce the burden, particularly so when, you don't have to do cesarean section anymore. Now, the other thing is to let our people know that, yes, much as you have to protect the baby, there's still a compelling need for the healthcare practitioners themselves to protect themselves, especially during labor. Be very careful with the sharps. Those who are not immunized and vaccinated, I'm talking about nurses and doctors, should do something about it. So that while we are protecting, the mothers and the neonates to come, we don't unduly expose ourselves. So all in all, I think this lecture has been very timely, and a lot of people will be a lot wiser for it, and everybody will come up with what works out best. But the summary is, we have the information, let's offer the patients, let's deal with the issue of discordant couples, especially with this amount of information we have. Let's let them know why it's very important to be fully investigated, to know where they are in the spectrum of infectivity and protection, and then what we need to do to reduce the incidence of vertical transmission. Thank you very much.
Thank you, Dr. Imesemi. Thank you so much. We will be going on to the post-quiz soon, but please, we just have one or two. We have several questions, in fact, that we cannot take because of time, but please do chat in your email address if your question was not answered, and this is your first time, and we will send the answers to you. Dr. OYELEKE will help us answer your questions, and we'll send it across to you via email. So this question I'm directing at Dr. Anyikam. I hope she's still on the call. It says, how do you determine when to start antiviral treatment for a hepatitis B pregnant woman? Is there a cutoff for the viral load at which you start this? If Dr. Anyika is on the call, can you please help us take on that question? Okay.
Hello.
Otherwise,
yeah, hello.
Oh, yes, I can hear you, Dr. Anyika.
Okay, good afternoon.
Go ahead. Good afternoon.
I'd like to thank Dr. OYELEKE for the great talk, but she actually answered this question in her talk. So I'll defer the question back to her, because towards the end of her presentation, she had a graph of how to manage patients. So I I give the question back to her so she can summarize.
Okay. All right. Okay. Thank you, Dr. Inkam. Okay, I think we will go on to the post-quiz now. We'll take on the post-quiz questions. Just be rest assured.
That question.
Okay.
Dr.
Okay.
Ima, Dr. If you can answer that question and just do a, key salient points recap before we go on to the quiz question. Everyone, if you can give us just a few minutes as we wrap up. Thank you so much.
Okay, so I think the question is on when to start treatment for someone with hepatitis B in pregnancy. So you've tested a woman and she's hepatitis B surface antigen positive. You do hepatitis B envelope antigen. If that is positive, you start treatment. If she can afford to do hepatitis B DNA, which we know is expensive, Dr. Imosemi clearly stated everything. We do it the cheapest at Luth and Naima at 20,000. If you send them to private labs and all, it ranges from 50 to 60. So you can send them to Luth if they can afford it. At 20,000 we do. So if the viral load comes and it's 200,000, then they need treatment. But we know in pregnancy, we do not want to expose them to medications unnecessarily, except it is absolutely important. We know this is important as well. So the recommendation, you start treatment from the 28 weeks and you continue the treatment for the hepatitis while you monitor. So typically how we monitor hepatitis is they do the viral load every 6 months or every year. Once a year or once every 6 months, and we monitor and you keep them on the tenofovir for long. It's difficult to say for how long. The tenofovir treatment is like an endless treatment except you monitor some other things. Because I know people are asking for how long. You leave them on that treatment. Because as you're trying to prevent issues with the child, we also know that a high viral load in a woman or in anybody for that matter is a prerequisite to trouble, liver cirrhosis or liver cancer. So that is what we do. You start treatment if E antigen is positive or if the DNA is more than 200,000. And you start tenofovir after you've checked the kidneys that everything is fine. You start tenofovir, the ciprofloxacin fumarate at 300 milligram daily. That is what you do, and you keep monitoring. When the woman gives birth, the standard recommended by WHO, by all the bodies of this Society for Liver Disease, both in Nigeria and elsewhere, is that once a child is born, within 12 hours of birth, the recommended evidence-based is to give hepatitis B immunoglobulin. However, we know how expensive that is in our environment. The World Health Organization said for those that cannot afford it, or for when it is not available, even if you can afford it, but you can't get it to purchase, you can give the birth dose of hepatitis B vaccine. And I'm also glad that Dr. Imosemi mentioned that it's been a challenge for most practices because they deliver Friday nights and immunization days are on Thursday, for example. So but for birth dose, there must be no barrier to administering birth dose. So this has to be emphasized. It has to be available in the labor ward fridge. That is the recommendation, and we must follow this to the letter. That is the recommendation because that would help to prevent. We know it's a chance, but it's a chance that nobody wants to take because if this child develops infection, we know 90% of them will go on to develop chronic infection, and 25% of this 90 would result into early premature death or complications of liver disease. So the recommendation is that all children must get the birth dose and must get it at the time of birth, not 2 days after birth, not a week afterwards, please. So that is what the World Health Organization is saying, and that's what everybody is trying to support. Because the plan, the focus is to eradicate, so they call it the 90-90-90. 90% of every hepatitis would have been tested by year 2030. 90% would have access to treatment, and 90% will be able to reduce risk and all that. So that's the essence of all this, attempting to treat whoever needs to be treated using all the guidelines available. I know that there are not so many hepatologists around, and the World Health Organization is even saying most doctors should be able to manage, and we leave the complications to the specialists. So that's why they brought that. The algorithm is just a guide. So you can actually manage when you now see that, okay, this have done it to the bit and there are other issues, then you can refer to the specialists in places where specialists are not readily available. And I must also emphasize this. I think somebody mentioned this as well. We have to protect ourselves. We have to protect ourselves. Studies have shown that about 18 to 20% of healthcare workers are exposed to hepatitis and have hepatitis infection. So we need to get tested. Somebody posted a question of, I received vaccination in 2006. For healthcare workers, we need to routinely test ourselves. And what are we testing? Even if you've completed your immunization, the 3 doses of 4, whichever one that you took, of immunization for hepatitis, you should check periodically, maybe once in 5 years or once in 10 years, check the surface antibody, quantify it. That determines whether you have enough protection or not. If you could quantify the surface antibody or anti-HBs and it's less than 10, then you require a booster dose. If it is more than 10, then you do not require a booster dose. This is particularly for healthcare workers. It's always good for us to check. For others, there will be no need because we are in a high-risk job. It's very, very important to get that done and to get tested.
Thank you, Dr. Oyeleke. Yeah, you did justice to that. Thank you very much. So we know we are past the hour. We'll just quickly, please spare some minutes to answer the post-quiz questions, and Dr. Oyeleke will quickly take us through the answers to that. We could please share the post-quiz questions now, and then the polls. Great. Dr. Oyeleke, please, once we are done, you could please take us quickly through the answers, and we will close up. Thank you. Please just spare a few more moments to answer the questions. Thank you so much.
Hello, how do I scroll down?
To see the questions, you mean? To see subsequent questions. There's a next button. There should be a next button, right?
For you as host, you can answer the question, but if you just look to the right, you see where you can scroll down with your mouse.
Okay. I can't do, okay, so maybe somebody will do that for me. I can't seem to. Okay, so the first question is.
People are still answering. Dr. Oyeleke, people are still answering.
Oh, sorry?
People are still taking the quiz. When they finish, then we can say the answers.
Okay, all right.
Thank you.
You're welcome.
Okay, so we have someone saying they can't see the quiz. I'm not sure why. If you're using a phone or a laptop, some people have already started. Someone has already submitted. So I'm not sure why it's not popping up for you. Thank you to everyone who has submitted. Still waiting for others to submit. Dr. OYELEKE has taken us back to school on hepatitis B virus and pregnancy. A lot of answers coming in. A lot of people are finishing up. Thank you. We see the results coming in. We're taking note of all the emails being shared. Thank you very much. So we know that a couple of us are taking this call as teams in our health facilities. And so that means we would have only one person's email, the person who actually registered for the call. And so if you know you want us to send the resources to your email and you didn't personally register for the call, but you're listening in on someone else's device, please do share your email address and we'll make sure you get it. We apologize for everyone's question who wasn't answered, as when we're sending the slides for today and the video and audio recording, links to the video and audio recording to all the emails, we will include all the questions and the answers Dr. OYELEKE gives as part of the resources for the call. We thank everybody joining us for the first time. We hope that you'll be repeat attendees. This session holds every third Thursday of the month at 2:30 to 4 o'clock. Reproductive health, we discuss all things reproductive health, chronic disease management, whatever we see. And if you have topics that you would want us to discuss, kindly chat it in and we'll schedule those as well. Every last Saturday of the month, we hold an echo session as well, but that is for pregnant and delivered mothers, women of reproductive age, their caregivers, and healthcare providers who give them service delivery. On the Saturday, the 29th, which is the last Saturday of August, we'll be having a session, and the topic is exercising in pregnancy, the do's and don'ts. And the mDoc fitness coach, Coach Wilson, who has over 20 years experience and education in providing, exercise therapy for people living with regular and chronic health needs. We'll be speaking to all our women of reproductive age, their support givers, and the healthcare providers. So make it a date with us. Okay, we have 51% of people who have turned in. We'll just give one more minute. Thank you to everyone staying on the call. We'll just give one more minute to do this. And just announcing our upcoming events. For September, the next call for healthcare, the Healthcare Workers Edition, is holding September 17th. The topic is co-managing diabetes and obesity in a pregnant woman. And we have our hub expert, subject matter expert, Dr. Ugochi Akoma. She's a fetal maternal consultant, and she who specializes in high-risk pregnancies, and she'll be here to take that session. Promises to be exciting. And September 26th, which is the last Saturday of the month, we'll be having the September Echo for women of reproductive age, and it is on diabetes and pregnancy, what I need to know about controlling my blood sugar. And this session will be directed at the women themselves, but we always encourage healthcare providers to come as well so that they can learn how to better counsel and what information and practical tips they can share in improving health promotion and counseling for the women that they serve. Okay, so where are we with the polls? We have 60%. If you permit me, we'll just give 30 seconds more and end the poll. So 30 seconds more. Okay. So Annie, can we launch the results? And Dr. OYELEKE, over to you. Would you want me to read it out and then you say the answer?
Yes, please.
Okay. So number one question, concerning hepatitis B infection in pregnancy. All pregnant women should be tested for hepatitis B infection, even if they have been previously vaccinated or tested. 98% of people said this is the correct answer.
You're correct.
Sorry?
That's correct.
Wonderful. 2% of people said generally pregnant women should be tested from the second prenatal visit, and that is wrong. The correct answer is option A. All pregnant women should be tested for hepatitis B infection, even if they have been previously vaccinated or tested. Question number 2. Concerning hepatitis B infection in pregnancy, chronic infection occurs in about 90% of infected infants. 73% of people said true. Chronic infection occurs in about 10% of infected infants. 22% said true, and 4% said it is a known cause of fetal death during delivery.
So the answer is chronic infection occurs in 90% of infected infants.
In 90% of infected infants. Wonderful. So majority of people got the answer correct.
Right.
About hepatitis B prevention in pregnancy. All hepatitis B positive mothers should receive hepatitis B vaccination. 4% of people say this is true. Infants born to hepatitis B positive mothers should receive hepatitis B immunoglobulin and hepatitis B vaccination. 94% of people said correct. Wonderful. So majority again wins the day. 94% of people were correct.
So A is wrong because it said all hepatitis B positive mothers should receive vaccination. They are already infected, so you do not require vaccination once you're infected. I hope they understand why A is wrong. So I'm just trying to, so the answer is.
Thank you for that clarification. What about for 2% of people said a positive anti-hepatitis hepatitis B surface titer combined with a negative hepatitis B surface antigen at 12 months of age indicates an ineffective treatment for infants born to hepatitis B surface antigen positive mothers. Why is that wrong?
It's wrong because the positive anti-HBs means an ineffective treatment. So if you give somebody an immunoglobulin and we need to see that the anti-HBs, the antibody to surface antigen, has become positive.
Okay.
Do you understand?
Yes, Dr. OYELEKE, thank you so much. Number 4, in investigating hepatitis B in pregnancy, hepatitis B surface antigen should be tested. 98% of people said true.
That is true. That's correct.
Okay, and 2% of people said liver function test should be checked only if the pregnant woman has jaundice. And we know that is false.
Whether they have jaundice or not. It's part of the routine test we do.
Okay, so this has more variance. The next question has more variation in the answer. Concerning treatment of hepatitis B in pregnancy, all pregnant women with positive hepatitis B surface antigen should be treated to prevent fetal deaths. 10% of people said true. All pregnant women with hepatitis with hepatitis B envelope antigen should be offered treatment. 57% of people said true.
That's true.
So the majority got the answer. Okay, and then we have 20% of people saying pregnant women with hepatitis B viral load greater than 20,000 international units should not be treated. That is false, correct?
So we treat when the viral load is more than 200,000. But what the false thing is to avoid adverse effect on the fetus. Hepatitis B does not have adverse effect on the fetus.
Okay, great. And I'm going to share this up. I know that there were some tenofovir questions. So treatment with tenofovir should be started in the first trimester in pregnancy to prevent mother-to-child transmission. 12% of people said true.
It started in the last trimester, the third.
28 weeks, you said.
Yes, 28 weeks. Yes.
And there was a question, how long should it last for? That was one of the unanswered questions.
I think I answered that. So, and I said that tenofovir treatment has no definite duration.
Okay. So number 6, going along quickly, the infant of hepatitis B positive woman should receive hepatitis B immunoglobulin within what duration after birth to receive a good response? 71% of people said 12 hours.
12 hours, that's the correct answer.
Wonderful. The dose of hepatitis B immunoglobulin for infants is 69% of people said 180.
Yes, it's 180 international units.
People were really listening, Dr. OYELEKE.
Yeah, I'm happy.
Number 8, at what time interval should the second dose of hepatitis B vaccination be administered in a previously unvaccinated pregnant woman after the first dose? 84% of people said 4 weeks.
Correct.
Amazing. So nucleotide analogs for the prevention of mother-to-child transmission of hepatitis B are generally started at what gestational age? And 76% of people said 28 weeks.
So nucleotide or nucleoside analogs are the group of drugs that tenofovir belongs to. So tenofovir is a nucleotide analog. So you can use other drugs like entecavir or telbuvidine, so which are nucleoside or nucleotide analogs.
So 76% of people got this correct at 28 weeks. Okay, the last question, Dr. OYELEKE and everyone. The acceptable minimum hepatitis B surface antibody titer that confers protection against hepatitis B infection. 10% of people said 10 international units per liter.
Yeah, correct. 10.
Amazing. Amazing. Thank you everyone for joining the call. Thank you, Dr. Eimer, for facilitating the call. On all the questions, 10 questions asked, we see that majority got, in very high amounts, majority got the answers. We would, this brings us to the end of today's call. We would like to specially and very warmly appreciate Dr. OYELEKE for taking the call and being so thorough in, teaching us about hepatitis B, the best practices, in managing hepatitis B in a pregnant mother. We want to thank Alhaji Dutse Hospital for the case presentation. Thank you so much, Nurse Uchenna and your team. We would like to thank all our hub experts, our subject matter experts on the call, Dr. Dorothy, Dr. Imoseni, Dr. Aikam, all the doctors that called into this call. At the height of the call, we were over 120 participants in attendance, and that's not counting the people on the group call. We say thank you to everybody. I cannot end this call without appreciating the RICOM 3 consortium partners, JAPIGO, mDoc Healthcare, and HSDF. Thank you, Dr. Kohli, for leading this project. And we would like to, thank everybody and say have a great evening. We look forward to seeing you on our other calls. Thank you, everyone.